With us now is Professor Henry John Christian de Vries. He is a dermatologist and professor of skin infections at the University of Amsterdam and an expert in clinical, epidemiological and diagnostic aspects of STI and emerging skin infections. And we are now speaking with him on his presentation, Can Pre- or Post-Exposure Antibiotics Prevent STIs, as part of the EADV session STI Prevention. Dear Professor de Vries, thank you for taking the time for this interview. To introduce our topic, could you provide an overview of the current epidemiological trends in STI and explain why the research and implementation of pre- and post-exposure antibiotic prophylaxis is particularly relevant in this context?
Okay. So what we see in the last 20 years or so in Europe, in most European countries, is that there is a decoupling taking place as far as the HIV epidemic on the one side, where we see the incidence is decreasing, and on the other side we see the bacterial STIs like gonorrhea, but also syphilis and chlamydia, they are rising. So that's what we call the decoupling of these two epidemics. And that's quite remarkable. And it probably has a lot to do with the biomedical interventions we have nowadays to fight HIV transmission. For example, treatment as prevention, where patients who live with HIV are put under treatment and they get an undetectable viral load, and therefore they cannot transmit the virus anymore to their sexual partners. Also PrEP for HIV, pre-exposure prophylaxis, where we give HIV negative persons who are at increased risk to get HIV, we give them antiretroviral medication, and therefore they cannot get HIV. Those are very effective, and we see the effect on in the decreasing numbers of HIV infections and diagnosis. But they don't help with STIs. So we see the bacterial STIs, they are on the rise. And DoxyPEP, so that's Doxycycline post-exposure prophylaxis, that's what's being discussed most nowadays, where you take 2 tablets of 100 milligram Doxycycline, preferably within 24 hours after being exposed to bacterial STIs, but at the least within 27 hours afterwards. They have a good effect in preventing especially syphilis and chlamydia infections. We don't see any effect in gonorrhea. That probably has to do with antimicrobial resistance, where most gonorrhea strains that are circulating now are resistant to doxycycline.
In your presentation, you emphasized the successes of HIV biomedical interventions such as treatment as prevention and pre-exposure prophylaxis. Which specific mechanisms of these strategies could be applied to the prevention of bacterial STIs, and what role could doxycycline play in this context?
Yeah. So first of all, treatment as prevention works in chronic infections. And most bacterial STIs that we are dealing with now, chlamydia, gonorrhea and syphilis, they are acute infections. Once you're diagnosed and you get treatment, you should be cleared of the infection. And that's different from HIV. So in that sense, the dynamic of the transmission and also the epidemiology is quite different. As far as prophylactic biomedical intervention, HIV works excellent. If we give 2 antiviral medications, it really blocks HIV transmission to those who do not have HIV. The problem with using antibiotics in the same way to prevent bacterial STIs is the emergence of antimicrobial resistance. We see a direct correlation between the population level antibiotic consumption on country level and the prevalence of resistant bacteria in that country. And that is quite worrying because in the end we will with this kind of consumption, lose the battle against bacteria. And in the end, it is projected that by 2050, about 10 million people will die yearly of untreatable bacterial infections because the drugs, the bacteria that cause these deadly infections cannot be treated any longer with the current number of antibiotics that we have at stake. So we should be more careful and more rational in using antibiotics. And that's the problem, or at least the problem as I see it with DoxyPEP, is that it's not a careful and rational way of using these antibiotics, because they will only increase resistant bacteria.
Given the increasing resistance, particularly in gonorrhea, how do you assess the risks and benefits of using antibiotics as pre- or post-exposure prophylaxis? Do you see a potential for exacerbating the resistant problem with wider application of these prophylaxis?
Yes, I think the most worrying bug that we're facing at the moment with bacterial STIs is gonorrhea. We have one last resort medication, that's ceftriaxone at the moment, where we know beforehand that it will work, because there is still, luckily, very little resistant strain circulating at the moment. But from all the historical events with gonorrhea treatment, we know that in the end there will be a moment that ceftriaxone will also become resistant at a wider scale as far as gonorrhea strains circulating. And with using more antibiotics, we will only bring this point in time closer to the present. So that's why antibiotic stewardship is so important at this moment.
Mpox and the rise of congenital syphilis currently pose significant challenges. How should dermatologists and venerologists adapt their prevention and treatment strategies to effectively address these growing threats?
Yeah. I think both syphilis and Mpox have proven that dermatological knowledge, being able to interpret the visual aspects of clinical lesions and come up with a differential diagnosis is very important. So dermatologists have a central role in recognizing patients with Mpox and also of syphilis. The problem with Mpox is that it's a very acute presentation. People are really sick, and as we know, in most countries it is pretty hard to get an appointment with a dermatologist. There's a long waiting list. So by the time someone with Mpox reaches the dermatologist, the infection is already over. But dermatologists can help training other clinicians who are in acute medicine to recognize Mpox.
DoxyPEP has been discussed as a potential approach to prevent STIs. What evidence is currently available regarding its efficacy and safety in practice? And what concerns do you see regarding a possible shift in the resistance spectrum?
Yeah. So there currently are 4 trials have been done, and most of these trials have been published also, where we see an effect of DoxyPEP as far as the prevention of syphilis and chlamydia, as I already said. But in settings where gonorrhea strains circulate with high resistance against doxycycline, it's not effective against gonorrhea. These were open trials, so there wasn't a placebo arm, and that makes it very difficult to gather data for modelers to see what the long-term outcome will be of the implementation of DoxyPEP on a larger scale. So we really miss the effect, what will be the effect of doxycycline as far as the emergence of antimicrobial resistance. And another point of concern is the effect on the microbiome. We know that if you use doxycycline or any other antibiotic for a long time, it will affect your microbiome. And there's a direct correlation between the state of the microbiome and all kinds of health issues. It's an emerging field, but it's also what's worrying me. So not only for the population at large, but also for the individual patients, I think that at this point in time we lack the necessary data to advise doxycycline being used at a wider scale.
You mentioned a paradigm shift in chlamydia screening. How could this be implemented in dermatological and venerological practice, and what impact do you expect on the prevalence and management of chlamydia infections?
We know that currently not all dermatologists see patients who are worried about STIs. In this sense, STI has increasingly become a public health issue, also seen in public health settings like sexual health centers, for example. The paradigm shift is about testing chlamydia in patients without complaints. So if someone with complaints shows up that could be caused by chlamydia, for example, pain in the belly, urethritis, etc., of course you should screen for chlamydia and also treat it if it's possible. But it's about people who are worried that they might have an STI, but they don't have any complaints, that I would say stop testing for chlamydia. And that is based on increasing evidence that the long-term outcome of an asymptomatic infection of chlamydia is very good. It's not associated with ectopic pregnancies and also with pelvic inflammatory disease, in contrast to the symptomatic chlamydia infections. Those should be diagnosed and treated.
Thank you so much for the interview.